Yeah, so the classification of salivary glands are there are major salivary glands such as parotid. It is the largest gland of the salivary area, weighing about 15 grams each. The parotid duct, which is called as Stenson duct, is about 5 centimeters long and has thick walls. It opens on the oral surface of cheek, opposite to the upper second molar. The next is submandibular gland. Yeah, right there. The next is submandibular gland. It is a regular. It is irregular. It is in irregular form and about the size of a walnut. The submandibular duct, which is called as Wharton's duct, is about 5 centimeters long and its wall is much thinner than of parotid duct. Okay, so the parotid duct, it is having a thick wall, and submandibular gland, it is having a thin wall. Finally, it ends up in the opening into the summit of the sublingual papilla here, situated in the floor of mouth on the side of frenum. Okay. Next is sublingual gland. It is about 15 ducts which opens directly into the floor of mouth. Sublingual gland, it has 15 ducts. It's very small ducts which opens directly into the floor of mouth. The duct of sublingual gland is called as bathroom duct, and there are 8 to 20 in number bilaterally. Okay.
Okay.
So these were the major salivary glands. Then there are minor salivary glands such as labial glands onto the lips, buccal glands, cheek, palatine glands, palate, glossopharyngeal glands on the tongue, then lingual glands and incisive glands. Okay. Now, disorders of salivary glands. The classification of salivary gland disorders are, first was the classification of the salivary glands, major and minor. Now, salivary gland disease or disorders. So, the classification of salivary gland disorders are A, developmental disorders such as aberrancy, aplasia, hyperplasia, atresia, accessory ducts, diverticuli, congenital fistulas. Then there are functional disorders such as sialorrhea, xerostomia. Then obstructive disorders, sialolithiasis, mucus plug, structure and stenosis, foreign bodies and extraductal causes. Then there are cysts. Cysts are mucocele and ranula. Then asymptomatic enlargement like ciliosis, allergic, associated with malnutrition and alcoholism. Infections, viral, bacterial and mycotic infections. Autoimmune disorders such as Sjögren syndrome, Mikulicz disease, eupyroid fever, recurrent non-specific parotitis. Then neoplasms such as benign and malignant. Again, these classification, they have sub-classification. Okay. Now, what are developmental disorders of salivary gland? First was aberrancy, the situation in which the salivary gland tissue develops at the site where it is not normally found. Okay, it is the change of placement. It is also called as ectopic salivary gland. True aberrant salivary glands are most frequently in cervical region near the parotid glands or the body of the mandible here. Okay. The clinical significance, they may become the site for the development of retention cyst or a neoplasm. Anything less, it is of concern, and anything more in the body, it is of more concern. Okay. Then next is aplasia or hyperplasia. It is a congenital absence of the salivary gland. Causes, it result due to regional action of some disturbing influence in the early fetal development. Management, institution of scrupulous oral hygiene. Hyperplasia of salivary gland causes hormonal disorders, metabolic disorders, autoimmune syndromes associated. Clinical features, prevalence, it is more common in minor salivary glands of the palate. Symptoms usually asymptomatic. Next is atresia. It is a congenital occlusion or absence of one or two major salivary ducts. Okay, major salivary ducts. Accessory ducts, it is an accessory parotid lobe, is the most common development anomaly. The important lies in the fact that any of the disease can affect the salivary glands, may involve the accessory lobe or lead to diagnostic confusion. Next is diverticuli. They are the small pouches or outpocketing of ductal system of one or the major salivary glands. Small pouches, okay, or pockets formed out of the ductal system. See, the duct is coming, okay, and in between the duct there is a small pouch. So what happens? The collection is there, and of this, due to this, recurrent infections are there because there is a collection. It may form a stone and may block this, and there may be a bacterial infection. So recurrent parotitis is there. Okay. Then functional disorders. Functional disorders, first is sialorrhea, like thylism. It is also called as thylism. An increased salivary secretion, it is termed as sialorrhea or thylism. Okay. Mechanism, stimulation of the parasympathetic system causes profuse secretion of watery saliva. Etiology, drugs having the ability to stimulate salivary flow known as sialogs. Local factors like NAC, acute necrotizing ulcerative gingivitis, and erythema luteforme. Then systemic disease such as Parkinson's disease, epilepsy or paralysis, psychiatric factors such as facial paralysis. Clinical features, drooling observed in infants is related to the inadequate swelling rather than excessive production and development of the cheek scarring. Management, no treatment in children less than 4 years of age. Oral motor training, biofeedback, train the patient to swallow more frequently. Removal of local factor if possible. Dental disease, nasal airway obstruction, and inappropriate medications. Drug therapy in this is anticholinergic drugs, atropine sulfate. Then atropine induced in the inhibition of salivary occurs within 30 minutes to 1 hour. The usual oral dose of adult is 0.4 mg every 4 to 6 hours. Atropine sulfate is contraindicated in patients with asthma and glaucoma. Other drugs are scolopin and methylene propyline. Surgery is a primary recommendation in individuals in those that have failed for non-surgical therapy for minimum 6 months. Otherwise, non-surgical therapy is continued. Next is xerostomia. It is the subjective clinical condition less than normal amount of saliva. Means the saliva secretion is less. Etiology, number 1 is radiation induced. See, the patients who are undergoing radiation therapy after the cancer therapy or anything, they are more susceptible to this. The ionizing radiation to head and neck region for treatment of cancer. Radiation sensitivity decreases in the following order: the parotid gland, submandibular, lingular to minor glands. Then serious acinar cells appears to be more sensitive in this. Then pharmacologically controlled this xerostomia. The drug which causes xerostomia includes anticonvulsants, antiemetics, antihistaminics, antihypersensitive, and antispasmodics. So these all drugs, they cause xerostomia. Then systemic alteration resulting in xerostomia, they are nutritional deficiency states like pernicious anemia, iron deficiency anemia, and deficiency of vitamin A, and fluid loss associated with the hemorrhage and sweating, diarrhea, and
Vomiting.
Clinical feature: increased thrust, difficulty in swallowing, speech, and eating dry food, burning and tingling sensation in the mouth, intolerance to the dental appliances, dryness of the lining of oral mucosa, atrophy of the papillae, increased incidence of dental caries, candidiasis, fissuring of dorsal surface of tongue, angular cheilitis, and swelling of the salivary glands. Correct. So all these things, these are very important things, and the patient is disturbed out of these things because of many factors, such as if it is not if he is having difficulty in swallowing or speaking, then obviously the whole thing will change. Okay. Now, management is stimulation of salivary production, the local stimulation by chewing off gum, mints, paraffin and citric acid containing lozenges. Then systemic stimulation by bromoxin dose. In adult, it is 8 mg 3 times a day. Then anethol trithelion acts by neurostimulation, dose 1 to 2 tablets. It means 25 mg 3 times a day. Then pilocarpine, dose is 5 mg 3 times a day. It should not be used in patients suffering from asthma. Okay. Then symptomatic treatment is salivary substitute. They contain carboxymethyl cellulose or hydroxyethyl cellulose as lubricants, and variety of artificial sweeteners, preservatives, and fluoride salts. Okay. The obstructive disorders such as, then we come to obstructive disorders such as sialolithiasis. It is also called as salivary gland stone or salivary gland calculus. These are stones within major and minor salivary glands. Definition: it is the formation of calcified concentration within the parenchyma of the ductal system of the major or minor salivary glands. Okay, formation of calcified concentrations. So what will happen? It will slowly occlude the duct.
Block the duct.
And there is a back pressure on the gland. Okay. So etiology and pathogenesis, neurohormonal mechanisms, metabolic mechanisms, prevalence: submandibular gland 83% calculi are more common seen in submandibular gland than in parotid 10% and sublingual 7%. Okay, so in submandibular, maximum of calculi are seen. Correct. So types of submandibular gland sialolithiasis are ductal sialolithiasis and glandular sialolithiasis. Clinical feature: encountered in middle-aged patients, predilection of occurrence in men, size from few millimeters to the several centimeters also. Symptoms: intragranular stones seem to cause less severe symptoms than extragranular or intraductal types. The patients complained of intermittent transient swelling during meals, which resolved after the meals. Occlusion of the duct when under pressure produces pain. Signs: the pus may extrude from the duct orifice. The soft tissue surrounding the duct shows a severe inflammatory reaction, which may appear as swelling, redness, and tenderness. No saliva is seen to be coming out through the duct orifice. Stone is stone in the minor salivary glands, and sialolithiasis is sialolithiasis of minor salivary gland is rare occurrence. Common site is buccal mucosa. So there will be a generalized inflammation of the buccal mucosa there. Okay. In radiographic feature, the projection of the submandibular duct stone is submandibular occlusal view like this for the parotid
Okay.
gland, periapical view for the buccal vestibule. Sialography is indicated when sialoliths are radiolucent. Shape, it is usually oval shaped and is cylindrical with multiple layers of calcification. Diagnosis by virtue of palpation. Okay, then metallic duct probe can also be of value. Radiographic examination and sialography. Differential diagnosis, there may be a gas bubble or sometimes hide bone. Hide bone is camouflaging it. Myositis ossification, then fibrinocytes, then calcified submandibular lymph nodes, or chondrodystrophic calcification congenitala. But most of the times it is misled with the hide bone or gas bubble. Now these were taken from a book. This is the size when taken out. The management is manual manipulation of the stone. By manual manipulation, one finger is inside the oral cavity and other is
Extraoral.
And you can manipulate the stone and take it out from the orifice. Try to take it out from the orifice, or bring near the orifice and then slight incision is there and it will be taken out. The stone in the submandibular gland, if the stone is palpated near the orifice of the duct, it can be removed by an incision and made directly over it through the mucous membrane of the mouth. The stone in the submandibular duct, excision and the gland is excision of the gland is advised sometimes, and then antibiotics if acute infection is present. Mucus plunges. These are incomplete mineralized sialoliths. Okay. So if they are incomplete, so if you increase the salivary flow by giving them the proper medicinal treatment, they wash off. Then strictures and stenosis of the ducts. The etiology is irritation, acute trauma, tumor. Types are papillary obstruction and duct obstruction. Next is cyst of salivary gland. So cysts are number one. These are the things you commonly encounter in your practice. Okay, mucocele. Definition: it is a term used to describe the swelling caused by pooling of saliva at the site of injured minor salivary gland. Types: mucus exacerbation and mucus retention. In mucus exacerbation, it is caused by laceration of minor salivary gland by the trauma, and in mucus retention, it is caused by obstruction of minor salivary gland, which causes the backup of saliva. Pathogenesis: the cut of traumatic defect of salivary gland is responsible for the production of mucus exacerbation mucocele. So these mucocele, they have high tendency to recurrence. Yeah. So clinical feature: site very common in the inner aspect of lower lip here. Okay. Age and sex varies with the peak frequency in third decade, but most of the cases occur before age of 50. Retention cyst occurs most often in older patients, whereas mucous extravasation cyst occurs in younger patients. Okay, retention cyst in older one and exacerbation in younger one. Symptom: patient may complain of painless swelling, which is frequently recurrent. The painless swelling, but recurrent. Okay, the swelling may between develop in at the meal time also. Mucosal of the upper lip. Size: majority of them being between 5 to 10 millimeter in diameter. Superficial cyst appears as bluish mass, and deep lesions, they have color of normal mucosa and are firmer. Shape: the swelling is round or oval or smooth, as it cannot be emptied by digital pressure. On aspiration, it yields a sticky, viscous, clear fluid. Correct? The differential diagnosis is vascular lesion, sometimes superficial non-keratinocyte cyst, early mucoepidermoid tumor, or adenocarcinoma. Okay. Management: complete excision if cyst under local anesthesia, and injection of steroid or cryosurgery can be tried to avoid the recurrence. So while excision of this mucosal, sometimes what we do so that the fluid does not spill on the sides, we aspirate the fluid, okay, and then mix alginate. Okay, mix alginate, viscous alginate, and then push it into the cyst. Now what will happen? The alginate will go inside and set. Okay, then you can excise it along with the lining, because you will have a definite borders. Otherwise, what will happen when you are excising the cyst and it ruptures? After rupturing, the membrane will contract and some remnants of the membrane will be there only, and they will again form a cyst. Okay. Ranula. Definition: the term ranula is used for the mucosals occurring in the floor of mouth in association with the ducts or submandibular or sublingual glands. Okay, sublingual swellings, okay, in the floor of mouth. Types: superficial and plunging. Clinical feature: they are usually unilateral. Age and sex occurs usually in children and young adults. No sex prediction. Then on the floor of mouth, mostly on the floor of mouth, below the tongue and on the side of frenum. And appearance is produced blue swelling like a frog's belly. Symptoms: it develops as slowly enlarging painless mass on one side of the floor of mouth. Big ranula may cause difficulty in speech or eating, and they are mostly in spherical or dome shaped, and the size is smaller in early morning and large just before the meals because of the collection of saliva. The consistency is soft and fluctuant, cannot be emptied by pressure or and these are non-pulsatile. Okay, fluctuation and transimulation, both tests are positive. Then aspiration, it yields sticky, clear fluid. Differential diagnosis: sublingual dermoid or submandibular lymph node swelling. Okay, management: surgical excision and partial excision with marsupialization if the content is more. You can see the swelling, slightly bluish in color. Same in this also. We take out the fluid, okay, mix the viscous alginate and push it with the help of syringe before setting. Otherwise, it will not.
Okay.
Okay, before setting, you push it in the site. Then asymptomatic enlargements like cirrhosis or sialadenitis, characterized by non-neoplastic, non-inflammatory enlargement of salivary gland. Enlargement is usually bilateral. Parotid gland is mostly affected. Swelling of preauricular portion of the preauricular means this area. Preauricular portion of the parotid gland is most common symptom. The condition is found in association with systemic disease, especially in diabetes and cirrhosis. These areas. The next is infections, viral infections. Various viruses such as paramyxovirus, cytomegalovirus, they are and Coxsackie virus. They may infect the salivary gland and cause its enlargement. Then mumps is an acute contagious viral infection characterized chiefly by unilateral or bilateral swelling of the salivary gland. It is also called as endemic parotitis. Etiology: it is caused by paramyxovirus, spreads from airborne infection to the infected saliva and possibly sometimes urine. Clinical features: age and sex more common in boys than girls, often seen between age of 5 to 15 years. Prodromal symptoms preceded by onset of headaches, chills, moderate fever, vomiting, and pain below the ear, which lasts about 1 week. Site: the parotid gland is most commonly involved. The both parotid glands may involve simultaneously. Symptoms: following by the sudden onset of salivary gland swelling, which is firm, somewhat rubbery or elastic without purulent discharge from the salivary gland duct. Signs: elevation of the ear lobule, pain upon the mastication, especially when eating sour food, and ductal papilla puffy and reddened. Diagnosis is salivary gland amylase level is increased, or paramyxovirus may isolate from the
Saliva.
complication is orchitis, okay, swelling in the inside the ear, then pancreatitis, meningitis, and other like deafness, mastoiditis, meningoencephalitis, and myocarditis. Okay, so this was the dangerous one. Management: most of the cases are self-limiting. Prevention with the live attenuated vaccine. Yeah. And symptomatic treatment is given to control pain and swelling for this. Okay. Then bacterial infections. Bacterial infection of the salivary gland may be recurrent and be generally developed owing to the spread of microorganisms formed by the oral flora along the excretory ducts. First one is acute bacterial sialadenitis. It is also called as acute suppurative parotitis. Etiology is microorganisms. They are caused by penicillin-resistant Staphylococcus aureus or Staphylococcus viridans. The predisposing factors are as dehydration, malnutrition, cancer, and surgical infections are there. So oral hygiene, poor oral hygiene, and anti-Parkinson drugs, diuretics, and antihistaminics. Okay. Clinical features: mostly occurs in adults. Unilateral involvement of the parotid gland is common. Elevation of body temperature on sudden onset of the pain at the angle of jaw. The parotid gland is tender, okay, enlarged, and the overlying skin is warm and red. Overlying skin is warm and red. The elevation of ear lobule is sometimes there. This is the ear lobule. Sometimes it elevates like this. Okay. The flecks of purulent material can be expressed from the salivary duct orifice. Parotid papilla may be inflamed and the pus may exude. The cervical lymphadenopathy usually develops in this. Pus is coming from the right parotid duct orifice. this is the submandibular one by manual palpation. Okay. And meticulous oral hygiene should be practiced. Soft diet should be given as chewing is painful. Specimen of purulent material sent to the laboratory for sensitivity and culture. High dose of parenteral antibiotics active against penicillin resistant staphylococcus. Electrolyte balance should be properly maintained with intravenous fluids. Autoimmune disorders, first one is Sjögren syndromes. It is a chronic inflammatory disease that predominantly affects salivary, lacrimal, and other exocrine glands. Okay, in Sjögren syndromes, what happens? Increase in salivation and lacrimal gland activation. So, what will happen? Watery eyes are there. Okay. It was first described by Henrik Sjögren in 1933. Types are primary Sjögren syndrome. It is also called as Sitka syndrome, or it consists of dry eyes, okay, and dry mouth, xerostomia. Both dry eyes and dry mouth. Secondary Sjögren syndrome, it contains of dry eyes, dry mouth, and collagen disorders, usually rheumatoid arthritis or systemic lupus erythematosus. Okay. Etiology and pathogenesis, immunological findings. The lesions in this syndrome is immunological mediated inflammatory exocrinopathy. It begins with a preductal infiltration of the tissue by mononuclear cells. The autoantibodies, the B cell hyperactivity may be result from the deficiency of suppressor T lymphocytes or B lymphocytes by producing autoantibodies against them. In clinical features, signs pus may be emitted from the duct. Angular stomatitis, denture stomatitis also occur. What happened in angular stomatitis? There is just like cheilosis. Okay. Then unilateral or bilateral enlargement of parotid gland. Mucosa is glazed, dry, and tends to form fine wrinkles. Soreness and redness of mucosa is usually the result of candidial infection. Okay. So there is a super infection of candida. Speech, there may be a clicking quality of the speech caused by sticking of the tongue to the palate. So if the dryness is there and somebody is speaking, so what will happen? The tongue will touch to the palate and it will stick. So there may be a difficulty in talking. The tongues develop a lobulated, usually red surface with partial or complete depapillation. There is also decrease in number of taste buds, which leads to an abnormal or impaired sense of taste. And dental caries is severe and gross accumulation of plaque may be obvious, just because there is a cleansing action of saliva is decreased. Lymph nodes and regional lymph nodes may be enlarged and tender. In general, the patient usually complains of dryness of eyes, dryness of pharynx, larynx, and nose are noted by some patients. These are accompanied by lack of secretion in the upper respiratory tract and may lead to pneumonia. The radiological features, sialography, if the salivary flow rate is equal, and the sialography can be used to detect the damage. Most typical finding in the Sjögren syndrome is that of sialadenitis, which typically produce a snowstorm appearance as a result of leakage of contrast of medium. Okay, in radiologically, you can see the snowstorm because of leakage of contrast medium. The atrophy of ductal tree may also be seen. Emptying of the duct is also typically delayed by some. In some cases, it will show cherry blossom appearance of the obstructive ductal system. These all symptoms we have read in the third year pathology books. Okay. In laboratory investigations, different types of stainings are there. Rose Bengal staining, then shimmer, sialometry, sialochemistry, hematological investigation, microbiological investigation, and salivary gland biopsy. Okay, so sometimes the lab person asks you, okay, how to investigate this? Because these are not so much common. These all are not common one. So, and especially the oral disease, they are not so much common. So you can guide them. Okay. Management, most of the patients are treated symptomatically. Keratoconjunctivitis is treated by installation of ocular lubricants such as artificial tears coating, methyl cellulose, and xerostomia is treated by saliva substitutes. The scrupulous oral hygiene and frequent fluoride application is indicated to reduce the caries problem, and then bromohexane can be used in some cases of Sjögren syndrome. Surgery for enlargement of salivary gland is only recommended when the enlargement is causing the discomfort of the patient. Next is UV parotid fever. It is the form of sarcoidosis, and it also causes Hereford syndrome. Okay, it consists of triad of the following: uveitis, the inflammation of uveal tract of the eye; parotid swelling; firm, painless, and bilateral enlargement of parotid gland; and facial palsy. Etiology: tuberculosis was earlier thought to be the causative agents. Then hereditary factors are there, and autoimmune mechanism is there. Clinical feature: age, third to fourth decades of life. And then there are prodromal symptoms lasting from the few days to several weeks and are usually initial signs of the disease, and complaints including fever, malaise, weakness, nausea, and night sweat. Appearance: it appears as a bilateral, firm, painless parotid swelling, and then the parotid swelling has last of several months to several years sometimes. The nerve involvement: most commonly nerve involved is the facial nerve. There is a unilateral or bilateral seventh nerve or facial nerve paralysis sometimes. See, it is easy to diagnose unilateral paralysis, but difficult to diagnose bilateral paralysis sometimes. Okay. Management is largely symptomatic as it may undergo spontaneous remission. The corticosteroids can be used in case of acute exacerbation. Then we come to the tumor of salivary glands. Okay, there are epithelial tumors such as adenoma, pleomorphic adenoma, monomorphic adenoma, adenolymphoma, oxyphilic adenomas, and other types are mucoepidermoids or eosinophil tumors. In carcinoma, there is adenocystic carcinoma, ACC, then adenocarcinoma, epidermoid carcinoma, undifferentiated carcinoma, carcinoma of the pleomorphic adenoma. Means pleomorphic adenoma, again, it tends to be malignant. Okay. The non-epithelial tumors, unclassified tumors, and allied conditions, benign lympholytic lesions, sialolithiasis, and onchocystosis. Then in benign, seldom recurrent Warthin's tumors, oncocytoma, monomorphic salivary adenomas. Then in benign, often recurrent in pleomorphic adenoma, mucoepidermoid tumor, low-grade mucoepidermoid tumor, and actinic cell tumor. In malignant, carcinoma of pleomorphic adenoma, ACC, actinic cell tumor, mucoepidermoid tumor of high grade, squamous cell carcinoma, and adenocystic carcinoma with or undifferentiated carcinoma. In benign tumors, pleomorphic adenoma, it is the benign mixed tumor of the salivary gland. It is also called as iceberg tumor, endothelioma, brachythema, or endopondroma. It is the most common of all salivary gland tumors. Definition: it is defined as a tumor of variable capsulation characterized by microscopically by architectural rather than cellular pleomorphism. Next, clinical features: site parotid, 90% of the intraoral palatal gland on the lip. In parotid involvement, superficial portion is most commonly effective. Okay. Age and sex: women to men ratio is 6:4. 6 women, 4 men. It is common in 4 to 6 decades, but also can be seen in young adults and children. Mostly it is common in 4 to 6 decades, but can be seen in young adults and children also. It means it was rare in that case. Symptoms: small, painless, quiescent nodule which slowly begins to increase in size, sometimes intermittently. Pleomorphic adenoma of palate, and ulceration following the biopsy of the lesion. Shape: the tumor tends to be round or oval when it is small and then grows bigger when it is lobulated. Size: it may increase to the cricket ball size or even more. Surface: its surface is smooth. Fixation: no fixation either to the deeper tissues or overlying skin. Consistency: it is a firm, rubbery to feel. Sometimes cystic degeneration may be seen. No ulceration of the skin, no pain. Facial discomfort: yes, it is there, and metaplasia is seen in liver along with the bones. Management: surgical excision. The parotid gland tumor and the involved lobe of the gland is removed. Intraoral lesions, capsular incision. Then hard palate is excised with the overlying mucosa. If the tumor is big and going to the hard palate also. Recurrence rate is low. It is 5 to 30% due to the hypocellularity and incomplete resection and encapsulation. Then only recurrence is there. Otherwise, there is no recurrence. Then signs of malignant transformations: accelerated growth rate, tumor irregularity on palpation, necrosis and painful ulcerations are there, and facial nerve involvement is there. So these are the signs of malignant transformation. Then there is monomorphic adenoma. Included in monomorphic adenoma are the basal cell adenoma and canalicular adenoma. The basal cell adenoma are clinical features. It occurs primarily in the major salivary glands, particularly in the parotid gland and intraoral or upper lip. Age and sex: it is commonly in males with 5:1 predilection. Older age group, usually in 60 years of the age, are effective. Okay. Symptoms are: tumor is usually painless and is characterized by slow growth. Management: it is treated by surgical excision and recurrence is seldomly seen. Then there is canalicular adenoma. It originates primarily from the intraoral SSD glands. The age and sex is common in the page of over the 60 years. There is no sex predilection. Then symptoms: it is present as a slow growing, well circumscribed, fine, firm nodule which particularly on lip. It is not fixed. Management can be treated by simple enucleation or surgical excision, and recurrence is rare. Then Barthen tumors, it is also called as adenolymphoma or primary cyst adenolymphoma. Okay, the clinical features are: the tumor occurs mostly exclusively in the parotid gland. It always occurs in the lower portion of the parotid gland, lower side of the parotid gland. The tumor is generally superficial, lying just beneath the parotid capsule or protruding through it. Age and sex: it is commonly found in males. Male to female ratio is 5:1. Then symptoms usually complained as painless, slow-growing tumor over the angle of jaw. Size and shape: the tumor does not attain larger size and usually size is 1 to 3 centimeter in diameter. It is spherical in shape. Surface: it is smooth and it is well circumscribed, movable. consistency, it classically feels duffy and compressible on palpation. And sometimes it is duffy and firm in palpation. Okay. Management, superficial periodictomy, and it seldomly recurs after removal. Otherwise, it will not recur. Surgical management of parietal tumor. See exposure, then identification of the facial nerve, and then the tumor is removed. In malignant tumors, mucoepidermoid tumor is there. The peripheral mucoepidermoid tumor, it accounts of 6 to 9% of the salivary gland tumors, and for about one third of the all malignant tumors of the salivary gland. It consists of both mucus as secreting as well as epidermoid type of cell, as it is, as the name suggests. It is of mainly two types, benign and malignant, based upon the clinical nature and histological feature of the lesion. Clinical feature sites about 60% occur in parotid gland and 30% in the minor salivary glands. Intraoral common sites, palate, buccal mucosa, tongue, and retromolar area. Age and sex, it occurs in equal distribution in men and women and occurs in the 3rd and 5th decades. Onset, it appears as a slowly enlarging painless mass which stimulates pleomorphic adenoma. It is not completely encapsulated and mostly often occurs in the cyst which filled with viscous mucoid material. The tumor, it is a tumor of the low-grade malignancy, usually appears as slowly enlarging painless mass. The tumor of high-grade malignancy grows rapidly and does produce pain, is an early symptom. So it tends to infiltrate the surrounding tissue and metastasize to the regional lymph nodes. Distant metastasis to the lungs, bone, brain, and subcutaneous tissue are common. It's very dangerous. So much more various findings such as lacrimination, trismus, nasal discharge, blood, tinged saliva, and facial nerve paralysis is seen in the high-grade malignant lesions. So management is surgical excision. Obviously, all the malignant tumors, they will go for surgical excision, followed by radiotherapy. Recommended for the intermediate grade for the tumor and high-grade tumors. Low-grade tumors can be managed by surgery alone. Then there is central mucoepidermoid carcinoma. The main clinical feature is it is common in females than males. Okay. And it occurs in mandible in premolar area. It does not extend anteriorly beyond the premolar region. Symptoms, the patient complains of painless swelling and there may be paresthesia of the inferior ulnar nerve. The sign, swelling may occur in the facial symmetry, tenderness is present, regional lymph nodes are enlarged. In radiological feature, it can occur, it occurs in the premolar molar area of mandible above the mandibular canal. Appearance, it's present in the unilocular or multilocular expansile mass. Margins, it is mostly often well defined, well corticated, and often crenated and undulating in the nature. There is a soap bubble or honeycomb appearance. Effects on the surrounding tissue, the buccal and lingual cortical plate, inferior border of mandible, alveolar crest may be thinned and grossly displaced. In mandibular canal, it depressed and pushed laterally or medially. Lamina dura of the teeth may be lost. Differential diagnosis, it may be diagnosed along with this ameloblastoma, odontogenic myxoma, or central giant cell lesion. It can be misleading to that. Management, it is treated surgically with an in-block resection, neck dissection, or post-operative radiation therapy may be required for the control of nodal disease. Then actinic cell tumor, it is also known as actinic cell or serous cell adenoma. It occurs in the middle age and twice common in the woman. Site is, it arises exclusively in the superficial lobe and tail of the parotid gland. Most common intraoral sites are buccal and oral lip mucosa. Then symptoms are it is painless and grows slowly. Some of these lesions run rapid course with the hematogenous and lymphatic metastasis. It resembles to the pleomorphic adenoma and is encapsulated and lobulated in appearance. Management surgical excision is done. Recurrence rate varies from 8 to 59%. Now, adenoid cystic carcinoma, it is also called as the basaloid mixed tumor or cylindroma. Okay. Clinical feature: the most common glands involved are parotid gland, submaxillary, and accessory glands in the palate and tongue. It occurs in the 5th and 6th decades of life. Symptom: presence of mass followed by local pain, facial paralysis in case of parotid tumor, and tenderness. Some of the lesions exhibit facial ulceration also, and other finding includes nasal obstruction, proptosis of eye, then sinusitis, ear infection, epistaxis, signs of cranial nerve involvement, and visual disturbances also. Management is surgical excision. In some cases is accompanied by X-ray radiation. Otherwise, the recurrence rate is about 60 to 92%. Okay, long-term follow-up is essential. So it has a ACC has largest recurrence rate of 92% also. Malignant pleomorphic adenoma, it is also called as malignant mixed tumor. The tumor occurs from 2nd to 9th decade, but most frequently in 5th to 6th decade. The tumor is usually larger than the benign one. There is often fixation of the tumor to the underlying structure as well as the overlying skin of the mucosa. The pain is most commonly a feature of the malignant than the benign pleomorphic adenoma. In benign, the pain is not there. Okay. Management surgical, these neoplasms exhibit a higher recurrence rate after the surgical removal as well as the high incidence of the regional lymph nodes involvement. Diagnostic tests of salivary glands: sialography, scintigraphy, ultrasonography, computerized tomography, then arteriography, biopsy, flow rate studies, and magnetic resonance imaging, means MRI.
Right.
Okay. So, salivary gland tumor is a vast topic and we have sized it.
But here, in Malaysia, salivary gland is being handled by ENT.
In Malaysia,
salivary gland is being handled by ENT instead of maxillofacial surgeon.
okay. So they are not handled by maxillofacial surgeons. Here in India, you know that maxillofacial surgeons, yes, in conjunction with ENT for medicinal therapy and all, they conduct both. See, if the symptoms are intraorally, then the patient will come to you.
Yes.
If the patient is, if the symptoms are not intraoral symptoms, then the patient will go to ENT. So it depends where the patient approached first. In some cases of fracture also, like mandibular fracture and or maxillar fracture or panfacial fracture, the patient sometimes go to a plastic surgeon. The patient sometimes go to a plastic surgeon and they take up the case. And since they don't have any idea about the occlusion, they fix the jaw like this.
Yes.
Later on, they come for correction to us. Okay. So we'll next class is on Friday.
Okay. Okay. I'll be slightly busier these few weeks, doctor, because the clinic is almost ready, so I'm always running here and there.
Okay.
Yeah.
So let me know. We'll arrange accordingly. Okay.
Yes.
And do send me that certificate copy. Okay.
Yes. I'll do it today.
Yeah. I'll send you my signature also. You can paste it on that.
Okay. Thank you.
Yeah. Bye.
Okay. Bye. Thank you.